through using plain language. And I want to cover becoming a PPI, the birth of the lay summary toolkit, how the toolkit works, then moving on to the wider picture of the trial designs and audiences and how to deal with complexity. And I think we've all seen these are complex things. And then I also want to bring it back really then to plain language and compassion between people who take part in the trial, who run trials. The three important questions you're probably wondering: who are you? What are you doing here? And why should we listen? Who am I? I'm just a guy who got caught up with some tricky medical situations, and one thing led to another. I ended up as the PPI lead in the DEFINE study, and the lay summary toolkit was a spin-off from that. I'm also a member of there's lots of acronyms here, Institute of Cancer Research, PPI Research Advisory Group, and I've been a PPI lead in a couple of other things. As far as the other two questions are concerned, I hope I'll be able to cover them in the next few minutes. I've actually been to Cambridge before, 48 years ago, in 1977, for an interview at Clare College, and I was planning on studying electronic engineering. My school thought I'd do well enough in my A-levels to get a place here. But unfortunately, Clare College decided they could rub along quite happily without me. And despite passing the entrance exam, they declined me. So I went to Birmingham University instead. I did all right. I met my future wife there. I've brought along my own heckler, actually, this afternoon, which means you don't need to heckle. Got a degree, worked in the North Sea for a few years, got a proper job in electronics, children and so on. And I thought of Cambridge occasionally. I thought, I'll be back. So I spent 90% of my life not being anything to do with PPI. And then 8 years ago, in 2017, my wife and I went to an alumni lecture led by Professor Gary Middleton at University Hospital Birmingham. And the lecture was entitled The Future of Cancer Treatment, Personalised Medicine and How It's Revolutionising Patient Care. And it was fascinating, so groundbreaking. And we thought it was really interesting in an abstract sort of way. And we signed up for more details at the end of the lecture because we thought it'd be good to keep in the loop. And then 3 weeks later, our older daughter was diagnosed with cancer. And of course, statistically, she shouldn't have got it. It was a rare, very slow growing form of soft tissue sarcoma. She'd had this lump for years. And all the doctors have said, it's a gland, it's a fatty lump. Don't worry. And of course, she worried. And in the end, we went private and we paid for consultations and for scans and this sort of thing. I'll come back to this later. Listen to the patient. This is so important in all circumstances. And everybody knows someone who's had their life turned upside down by this sort of diagnosis. And she had months of surgery, infections, more surgery, radiotherapy, scans, more scans, and all sorts of other treatments. And interestingly, we're at the radiotherapy centre in Birmingham, and who should walk across the waiting room but Professor Middleton with a patient. So not only do these gods design trials and such like, they also talk to patients on a normal day. Just after she finished her radiotherapy, and she's fine. Nothing to worry about now. I had an email from the Cancer Clinical Trials Unit at Birmingham saying, remember those lectures you signed up for? We're looking for people to join a PPI group. I'm just going to jump back a little bit there. There was a series of lectures and seminars and such like in Birmingham. And we went to sort of a few of them for about 6 months, this sort of thing. And then 2 researchers from the Cancer Clinical Trials Unit in Birmingham gave a talk about a new study which they were planning on doing, which was basically to look at consort, which I'd never heard of consort back then. And it sounded interesting, and they were looking for a PPI representative. And we had an email from a Dr. Christina Yap, as she was then, and I sort of put my hand up. And that early phase dose finding trial consort extension became defined. And the original design concept was to improve planning of early phase dose finding trials. And my remit was to give a public perspective to these things, to be involved in the actual process of design and management undertaking the study, ensure that the needs of patients were at the core of it. Public involvement in research means research that is done with or by the public, not to or for or about them. It means that patients and other people with relevant experience contributing to how research is designed and conducted and disseminated. It doesn't refer to people actually taking part in a trial. And the idea for a lay summary toolkit came about from this, because when we were doing the Delphi survey, which Christina has already alluded to, it became apparent that a lot of the items in there were just way too complex for non-experts to understand and therefore have a vote on. So we decided to form a PPI working group so we could come up with basically a way for researchers to get across how early phase trials could be reported to non-experts. And it became a separate sub-project within the main study. So first of all, you've got to know your audience. Who is a layperson? So obviously I went to the Cambridge Dictionary, which you must all have a copy of being here in Cambridge. And it says someone who is not an expert in, or who does not have a detailed knowledge of a particular subject. So the definition of a layperson depends upon who's asking. And we're all lay people to some extent. It doesn't matter if you're an electrician or a plumber or a virologist or a lawyer. A layperson is just someone who doesn't have your detailed knowledge. And which means that if you're a statistician, the layperson is basically anybody who isn't a statistician. So I asked AI how many statisticians there are in the world. It reckoned about 300,000, which means that's 1 in every 20,000 people is a statistician. So, it's basically, to a statistician, a layperson is everybody. And we defined a lay person. What's a lay summary? Concise, jargon-free. If you're looking at studies, then it's about its purpose, its methods, findings, its implications, written for a non-expert audience. And that's the important. It's not specifically written for patients. It's written for the non-expert. Try and avoid technical terms like, we've heard about posterior probability. Likelihood based on data might be a way of explaining that. Emphasizing real-world relevance. How has treatment helped patients? Not looking necessarily for biomarkers and this sort of thing. And if it's going to help, use visuals, use icons to show trial progress. How did we develop it? Well, first thing we did, of course, was to Google lay summaries in early phase trials. And we found a huge number of reports of early phase trials, and a very, very small percentage, maybe 1 or 2%, which actually had a lay summary, and they weren't very good. They were too long, too complicated. They weren't standardized in any way. You couldn't just glance through them and get the whole idea of what was going on. And we thought there was a need to actually have a template to help trialists create this sort of report. We looked at the available guidance from the NIHR and generic lay summary toolkits. We had input from the Institute of Cancer Research in-house scientific communication team to produce our initial version of the toolkit. And throughout all of this, we had lots of input from the PPI members of our group, particularly with the use of icons and things to make it striking, to make it easy to understand, and the use of lay language. So the toolkit which we developed is basically 3 components. It's a template Then there's an explanatory guidance which takes you through what you could put into the template, and then an example from a fairly complicated cancer drug trial. And there's 11 sections in this toolkit. And we've tried to make it concise and visually appealing and easy to read, with lay-friendly terminology. And there's a poster of it outside. So when you rush out for coffee at the end of my speech or before, you'll be able to actually have a look at it close up. This is basically how it breaks down. And I'm not going to go through. These are all the people that helped. There's probably more. If I've missed any names out, I forget things easily. You've basically got the sort of steps you might expect. Title, why was the research needed, what were the conclusions, who volunteered to take part, how did we deliver, how was it done? Because that can be one of the complex things. How do you actually give these drugs? Is it a tablet, is it an injection? What were the results? What worked well? What needs more work? And what didn't work well? How did patients get on with it? What were the side effects they have? And then what happens next? You're moving on to another trial. Do you need to study the results more? And then where can you find more information? Maybe the details of the original trial itself, who the sponsors were, who the pharma companies were. This QR code here, by the way, if I press the right button, that takes you to a link which has got the full toolkit you can download as well, just to make it a little bit easier. And then at the end, you acknowledge everybody that's worked on it, who took part in it, patients, maybe even their families, because in a lot of early phase trials, some of the patients don't make it to the end. So it's nice for the families to know that they've been helping out for future patients. So we'll have a look at a couple of bits of extracts from our example. And on the left, you've got the original text extracted from the original report. And you've got here, for example, there's so many drugs here. Like, I'm not even going to try and pronounce the drugs. I know there's a naming structure for drugs, but I'm just going to call them G and P and this sort of thing. In the abstract, it tells you what you need to know, but most people who don't do trials wouldn't necessarily understand that. So what we've tried to do on the example is, come up with a headline, first clinical trial. It's a bit like something out of the sun, first clinical trial to test a new drug combination. But you've got to make sure that you get the key information in the headline so that people are then happy to read through and they get some more information out of it, because it's all about communication. And you might have to explain terms like what's immunotherapy, what's solid tumours. You have to mention the drugs, but drop those out later. What about progression? Trying to take people through how the trial is run without going into all the really complicated parts of the trial itself. And again, on the left here, we've got the details of how the drug was administered, and it's quite complicated. So we've tried to make it tabular here. We just say how it was injected, was it put in a drip, how much was put in, how often was it administered, was it run on a cycle, and what happened whilst you're doing this? How are the patients monitored? Blood samples and heart monitoring and this sort of thing, urine samples and so on. And then what were the results? Happened? Did it work on some patients? Were there any patients who had severe side effects? Mention those. And we've got our normal emojis here. You got on your phone, happy, so not very happy. And then a little bit more about how the patients actually experience the trial itself. What happens afterwards? Where can I find more information and acknowledgements? And I encourage you to download it if you can, have a read through, because the guidelines also help you to translate from the complexity of a trial report to plain language. And as we move into more complex trials, and the lay summary toolkit is designed to help researchers write lay summaries for early phase trials. That was its core, but the general format can be applied to all types of phases, really. And as you get into some of these more complicated ones, I did a word cloud analysis of trials, and this is what it came up with in terms of complexity and such like. There are so many different things. I don't understand any of them, I don't think. But it's they're becoming so complex now. There's a whole new language to learn. And I think there's actually justification for a new version of the lay summary toolkit to suit the next generation of trials. And with the complexity, you have to think more about your target audience. It's not just about patients and the public. It's anybody who's involved in a trial that doesn't have the expert knowledge that some of these new types of trials requires, from funders and ethics advisors, regulators, basically anybody who's not at that top level where you've changed your trial design from a fairly standard one to a complex one. And of all these different groups of people, only 2 or 3 might actually speak your language fluently. So you need to adjust your funding applications, approvals and recruitment to make sure you're actually remaining inclusive for all of these people. Don't worry, I'm not going to go through it all. I've deliberately made this slide complex to emphasize how complex trials are. It's at least 10 stages, lots of parts of each stage. And normally a lay summary might only be in this bit when you're in interpretation report. That's what most people would think. I need to lay summary at the end of my trial. Tick that box, tick that PPI box. But you need to use plain language in all of these different areas, right from when you're recruiting, before recruiting, trying to get your grants, ethics advisors, and so on and so forth. And if you can build plain language into the whole structure of the trial, then it's easier to keep everybody informed and involved and engaged. And it makes it easier for you when you do report on it because you've laid all the groundwork for your plain language. Bayesian. I knew we'd have to get onto this. I'd like to dig into Bayesian analysis a little bit. Probably most of you know Thomas Bayes, 1700s. He was a man of God, a layman who became one of the first experts in this area of probability. In fact, he really invented this area of probability. And I gather that he did it because he was trying to prove the existence of miracles and using evidence to show whether or not they were more or less likely to exist. I'm not going to dig into all of his history. I mean, there's lots of articles and books about it. If you want to have a good read, I can recommend David Spiegelhalter's book, The Art of Statistics, chapter 11, which goes into it a little bit more. What I would say about Bayes is his essay, Solving a Problem in the Doctrine of Chances, is that whilst it's undoubtedly brilliant, it's not exactly a model of plain language. And when I was looking into Bayesian analysis, I was a bit surprised to learn that we all use it all of the time without really realizing it. Because it's all about making decisions based upon new information, whether or not it's working out which way you're going to drive to work, the weather predictions. I left the eggs in the fridge last night. Are they going to take longer to cook this morning? Dating, finance, pensions, gambling, so on. It's all about decisions you make based upon new evidence. And then we get to health, which is probably the thing that most people worry about the most. So time for a little diversion. And a warning, the next slide does have a CAT scan image on it, in case you're a bit worried. So once upon a time, about 27 years ago, there was a toddler who developed mastoiditis following an ear infection. The mastoid is the spit of bone behind the ear. And mastoiditis is an infection of that. It's quite serious. It needs rapid administration of antibiotics or possibly surgery. So she had a mastoidectomy operation to relieve the infection, but she subsequently developed brain abscesses, a bit like this, where the infection had gone through into the intracranial area. They're exceptionally rare and potentially fatal. And she had to undergo emergency brain surgery at a regional neurosurgery centre to save her life. And at the point of admission, her neurosurgeon told her parents that the mortality rate for a child in her condition, which is in a coma with brain abscesses, was 50% every 24 hours. And that's a scary statistic. And it's the very definition of urgency. So they operated within an hour of admission at 10 p.m. at night. And she lived. Good result. In the follow-up post-recovery, the father asked her original ENT surgeon, what are the chances of developing a brain abscess following an ear infection? And the ENT surgeon said, 1 in a million. And then the father said, oh, but she's had one. What are the chances of her getting another one? New data. And the ENT surgeon said, 1 in a million. And the father thought that maybe having had one, she was possibly more likely to have another one. So who was right? It's a simple enough question. And just to be clear, 27 years on, toddler is now all grown up, living in London, works in finance, and is absolutely fine. No recurrence. But this question has haunted the father for 27 years. And now that father is standing in front of a room full of statisticians who might be able to throw some guidance on it. But when I did this presentation, I wasn't standing in front of a room full of statisticians. So I asked AI, like you do, a font of all knowledge. So I asked, does my daughter's prior abscess increase her risk of another one compared to the doctor's 1 in a million? And to be fair, I asked 2 different AIs. I asked ChatGPT and I asked Grok. I asked them to come up, investigate, come up with some ideas. And what they basically came up with was, yeah, okay, so the original 1 in a million is about right. Slightly more than that, maybe 10 in a million. The chances of having a predisposing condition is maybe 1 in 10,000. And it guessed at the likelihood of the chance of developing an abscess if you're predisposed to complications following an ear infection. And this is the big unknown, this figure here, because they're so rare that nobody really knows very well. And then it worked that out together with the original general risk. And it came up with this figure here, that the likelihood that she was prone to these things was 50%, given what had happened and given how rare they are normally. And that then started me thinking, well, what are the chances of her having got one in the 10 years following that? And it showed the figures and came up with 1 in 200 per year, which is quite a scary possibility. So if you're over 10 years, the likelihood of it happening is 1 in 12. But don't forget, this bears back on that fairly unknown certainty, because 1 in 12 is not odds you would bet on, really, if this is going to kill you. So I asked it to recalculate. I dropped that 1% down to 0.1% and 0.01%, just to get a figure, get a feeling for how it would change. And if you drop it down to 0.1%, it becomes a risk of recurrence of 1 in 200. And 0.01%, it drops to 1 in 10,000. I mean, that's better risks than anaphylaxis. It's about the same as brain tumours, aneurysms. None of these things, you don't want to think about these things, but that sort of level of risk, it's not going to be very likely. So I think what that shows is you must be very careful with your data to make sure it's valid, it's accurate, it's well considered, because it can have implications. You know, your final information could be very sensitive to certain unknowns. And, you know, there's a limit to how many rabbit holes you actually want to go down with this sort of thing. Except I took one more step down. I followed Alice another step, and I looked in recent data about brain abscesses. And if you take mastoiditis as the complication, rather than just an ear infection, 6 to 23% of people with mastoiditis are likely to develop brain abscesses. So all of a sudden, that 1 in a million shoots down to really quite likely. I think it's definitely time to leave that particular one and get back to the safety of plain language. Einstein said, if you can't explain it simply, you don't understand it well enough. And Richard Feynman said, I'd rather have questions that can't be answered than answers that can't be understood. And then he won his Nobel Prize. And he said, if I could explain it to the average person, it wouldn't have been worth the Nobel Prize. So, changed his mind a little bit there. In The Selfish Gene, Dawkins said, when you're writing, pretend you have 3 readers over your shoulder: the layman, the expert, and the student. That he calls a student someone who's becoming an expert from being a layman, somewhere in their journey. He also suggests he should strip jargon from journals, which I tend to agree with. C.S. Lewis, when he wasn't writing The Lion, the Witch and the Wardrobe, wrote to an American schoolgirl who asked him for advice. And he said, take great pains to be clear. Remember that though you know what you're talking about, your reader doesn't necessarily. And so a single ill-chosen word can lead him to total misunderstanding. Be sure you know the meaning or meanings of every word. And George Orwell said, never use a long word when a short one would do. If you can cut a word out, cut it out. And never use a foreign phrase, a scientific word, or a jargon word if you can use an everyday English equivalent. Limit the use of jargon. How can I explain this more clearly? Read what you've written as though through someone else's eyes, and ask your mother, your brother, your grandparent, your child, your partner for their opinions on what you've written. And make sure it's not hidden in an appendix or behind a paywall. And always think, how can I explain this more clearly? Use graphics. Some of you might have heard of Hans Rosling, the late professor from the Karolinska Institute, who created essentially a software suite which allows you to show very, very complex data sets quite accessibly. And this one is, in fact, life expectancy against GDP per capita over time. And if it's quite a low resolution version of this, but if you watch it through, you can see it suddenly dips in world wars where all of a sudden life expectancy plummeted, and then it did it again in 1940. But generally speaking, as GDP increases, life expectancy increases. And it's broken into population sizes for areas and for countries. And it's a really impressive way of getting across data, simply that with a little bit of explanation, people can get straight away. And nice simple bar chart. Back to diarrhea, of course, and things like that. But if you zoom out on this particular one, you can see it actually forms part of a Sankey diagram, which is actually not quite as clear when you try and understand. So do be careful with your graphics, because they don't always work necessarily. Says he, having come up with the slide, which looks very clear. And then I start filling it with stuff as well. So for the people involved in the trial, it's all about viewpoints. Clinicians will be involved with patient care and ethics, building a personal rapport. Patients have got their personal experience, their hopes, anxiety, confusion, and statisticians will be looking maybe more methodological rigor for valid, unbiased results and to generalize to populations. And then there's areas where each of these groups interact. But the bit in the middle, which is the one I would like to think about, is where they all interact together. And the common ground between everybody in a group like this is really having compassion for other people's position, for their viewpoints, for their responsibilities and fears and cares and so on. And compassion can be the way that you can build links and communicate better. And how might that compassion actually appear in a trial? You might think of a trial as being a foreign country. And if you're a researcher, in a clinical trial is familiar territory. you've been there for a while, you know all about it. But to participants, it can feel like the most foreign country where they can't understand the science. It's full of unfamiliar terms, unclear directions, unspoken rules and cultures. And plain language can become their guide to this foreign country. It doesn't change the science, it doesn't change the facts, but it explains the route and interprets the signs and sort of walks beside the person. It's not a dummy's guide. This is about respect for getting information across, and it allows people to make informed decisions and builds trust and can show compassion through clarity. And you'll be relieved to hear this is the penultimate slide, I think. So to summarise, everybody's a layperson, and plain language really is the key to better understanding. And it's a two-way street. It's a thing which links us together. Clarity helps understanding, but jargon can limit it. Listen to the patient, because they live it 24 hours a day. The nausea at 3 a.m. and the aches and the pains and the despair and the hope, the minor side effect, which can contain a mine of information that won't necessarily show up as biomarkers or blood tests or scans. Remember, loss of smell in COVID, which became one of the major symptom indicators. And if you can access that wealth of information in a plain language, then you can enrich the data that you collect and help the patient to become a partner, not just a subject.